factors governing coronary blood flow. Uniqueness of coronary circulation. Anatomically, it supplies blood to the conducting system, 4 valves of the heart, 4 chambers, 4 valves, 2 septums, 16 subsegments, and 3 layers of the heart like epicardium, endocardium, myocardium. Heart gives rise to 2 great arteries and receives blood from 2 great veins. Then about the history of coronary arteries. In 14th century, Leonardo da Vinci mentioned coronary arteries in his book. In 15th century, William Harvey, who is the father of circulation, he said that blood moves around the body in a circulating manner from the heart. Then about the anatomy of coronary arteries. There are 2 coronary arteries, right and left. Left coronary artery arises from ascending aorta from left posterior aortic sinus. Left coronary artery comes from the left aortic sinus between left atrium and pulmonary artery. Then it gets divided into 2 branches, left anterior descending artery and left circumflex artery. Right coronary artery arises from right anterior aortic sinus between right atrium and right ventricle. Then left coronary artery course and supply. Left circumflex runs in the left crux, which goes posteriorly to the interventricular groove and supplies left atrium and left ventricle. Left anterior descending artery runs in the anterior interventricular groove and supplies anterior 2/3 of the septum, anterior papillary muscle, and whole of the left ventricle. Then about right coronary artery, it gives branch to the sinoatrial node as acute marginal artery supplies right ventricle. Then it goes as posterior descending artery into the posterior interventricular groove and supplies posterior part of the septum, posterior papillary muscles, and posterior part of the left ventricle. Then about cardiac dominance, artery which gives rise to posterior descending artery is called as dominant artery. Most often, posterior descending artery arises from right coronary artery. Therefore, coronary circulation is right dominant. In about 10% of the population, right coronary artery is small and does not give rise to PDA. In such cases, left circumflex continues as PDA. Such cases are called left dominant coronary circulation. In rare instances, PDA is supplied by both right coronary artery and left circumflex. Then coronary circulation is then called codominant circulation. Then about coronary veins, there are 3 cardiac veins which accompanies 3 major arteries. They are great cardiac vein, middle cardiac vein, and small cardiac vein. All 3 veins drains into coronary sinus, which then drains into right atrium. Apart from these 3 veins, we have anterior cardiac vein, Thespesian vein, bulbous cordis veins, which drains directly into the right atrium. Then about the arrangement of coronary artery into the epicardium, myocardium, and subendocardium. Epicardial vessels or conductance vessel, intramyocardial vessels or resistance vessel, and subendocardial vessels or end vessels. Then about the endocardial to epicardial relationship. When the ventricle contracts, muscular arteries get squeezed and the endocardium receives less blood supply. When the ventricle relaxes, vessels gets dilated and subendocardial part receives blood supply. That is, during diastole only coronaries receives blood supply. Then about the physiology, normal coronary blood flow is 0.6 to 0.8 ml per gram per minute. That is 250 ml per minute, which is 5% of the cardiac output. During exercise, coronary blood flow increases 4 times. Myocardial oxygen consumption in normal beating heart is 8 ml per minute per 100 gram. Then factors affecting the coronary blood flow. It has 3 factors: mechanical, metabolic and hormonal, and neural factor. Mechanical factor has 3 components. It includes phasic flow, auto-regulation of blood flow, and regional variation of blood flow. First, about phasic flow. In left coronary, blood flow is hardly 40 ml in the systole and it increases to 100 ml in the diastole. So it receives blood supply during diastole. In right coronaries, it receives blood flow both during systole and diastole, but in systole it receives little high blood supply. Then about the auto-regulation of blood flow, ability of the heart to maintain constant coronary blood flow in spite of various changes in the perfusion pressure. It's called auto-regulation of blood flow. In a pressure of about 30 to 120 millimeter of mercury, it maintains constant coronary blood flow. When the pressure goes below 30 or above 120, the coronary blood flow decreases. Then about the regional variation of blood flow. Now with the help of nuclear imaging, the exact blood flow of apex and base and various parts of the heart can be seen. Then about the metabolic factors. Factors which vasodilates the coronaries are adenosine, ions like potassium, H plus, calcium, carbon dioxide and oxygen, and prostaglandins. Factors which vasoconstricts the coronaries are thromboxane E2, endothelium, prostacyclin, bradykinin, and angiotensin 2. Then about the neural factor. In normal blood vessels, sympathetic response is extensive. Epicardial vessels contain lot of alpha receptors, so it causes vasoconstriction. And the endocardial vessels contain lot of beta receptors, so it causes vasodilatation. In an endothelium dysfunction or atherosclerosis, any sympathetic stimulation will lead to vasoconstriction. Then about the regulators of coronary blood flow. Epicardial vessels are flow sensitive, myocardial vessels are pressure sensitive, and endocardial vessels are metabolic sensitive. Then about the drugs which acts on the coronary circulation. If we want to decrease the heart rate, we can give beta blockers, which can increase the diastolic filling time and improves the coronary circulation. If you want to decrease the preload, in order to decrease the stress on the heart, we can give nitroglycerin and diuretics. If you want to increase the afterload, in order to increase the blood pressure, we can give phenylephrine. Thank you, sir.
So, now the first question to you is, why should we know about the anatomy of the coronary blood vessels? Have they taught you these facts in the undergraduate course? When you are doing your MBBS, did they teach you about the anatomy of coronary blood vessels?
Yes, sir.
Yes or no?
Yes, sir.
Yes.
Yes. Okay. So why do you think we should know so much details about the coronary circulation?
Sir, for anesthesiologists, intraoperative arrhythmia and MI can be a probable thing.
Very good.
And
are we seeing more number of ischemic heart disease or coronary artery disease patients nowadays, even at a very young age?
Yes. Yes.
Yes. Okay. So because of the lifestyle changes, people are becoming more sedentary. Food habits are changing. More junk is being eaten. So the incidence of coronary artery disease has tremendously increased compared to the years. Okay? So a patient coming with chest pain, you want to diagnose whether it is coronary origin or not. You should know, first of all, about the basic anatomy of the coronary vasculature. And if it is proved to be a myocardial ischemia or an infarction, you should be able to locate where exactly the constriction has happened or the occlusion has taken place. You should be able to locate it. And in case somebody brings an angiogram report and shows to you, unless you know the anatomy of the coronary, will you be able to identify where exactly the narrowing or the block has happened?
Yes.
You will not be able to, isn't it? So you should be able to identify where exactly the problem has happened. And as Dr. Sri said, intraoperatively, supposing a known myocardial or coronary artery disease patient comes for a major surgery, and intraoperatively he develops, unfortunately, some acute coronary syndrome incident, then unless you know the anatomy, you will not be able to locate which particular blood vessel has gone into a block and where exactly the lesion is happening. Okay. So from these points of view only, we have to know thoroughly, as an anesthesiologist, all the nature of the distribution of the coronary vessels, number one. In your description, you said about the right coronary and left coronary. And in the left coronary, you said that the main branches are left anterior descending and circumflex. Do these two branches do not have any further branching? Are there branches arising from left anterior descending and circumflex or not? Dr. Kayal, are you hearing
sir.
me? The problem is I'm not able to see any of your faces. All your videos are closed and it is like a blind man sitting in a dark room. I am talking. I am not able to see any expression or any reply from you. Very frustrating.
Yes, sir. Yes, sir.
What are the branches from these two vessels? And when while presenting, at least you can switch on your video and present. Last batch students were doing like that only. You people are shutting the video and answering. So,
Sir, left circumflex artery gives rise to left marginal.
obtuse marginal. Yes,
Yes,
very good. What about the branches from left anterior descending? Do they have some branches called diagonal and septal branches? Are
yes,
they
sir.
important or not?
Yes, sir. Yes, sir.
They are also important. Okay, so that
Yes,
also should have to be included in your description. That is
Okay,
point number 2. And point number 3, you said about the venous drainage. And what about the Thebesian veins?
Yes, sir. It drains directly into the right atrium.
Right atrium or left atrium? Do they cause some shunting?
Yes, sir.
So the venous drainage goes into the oxygenated side. That is the importance of that. Thebesian veins, which drain the myocardial tissues, they drain directly into the left ventricle and cause some amount of mixing of deoxygenated blood with the oxygenated blood. Okay, all the other things drain right into the right atrium through the coronary sinuses. Okay.
Okay, sir.
And with regard to the factors controlling, what is the importance of heart rate in blood supply to the heart?
Sir, blood flow to the coronaries occurs only during diastole.
Diastole, very good. So if supposing patient develops a tachycardia, what will happen? Supposing heart rate goes to 140, 150.
Yes, sir. It decreases the diastolic filling time.
Filling time, very good.
Sir. So then coronaries receives very less blood supply.
Perfusion. What is the importance of coronary perfusion pressure? I didn't hear that particular terminology in your description at all. What is coronary perfusion pressure? How is it calculated?
Sir, left ventricular end diastolic volume.
Volume or pressure?
Pressure, sir. Minus aortic pressure.
Is it the other way around or is it the...
Sorry, sir.
What you are saying is...
Yes, sir. Aortic pressure minus left ventricular end diastolic pressure.
Is there no role for mean arterial pressure there? Okay, so every organ has got a perfusion pressure. For example, if you take the kidney, it has a perfusion pressure. If you take the liver, it has a perfusion pressure. Every organ has got a perfusion pressure. Cerebral perfusion pressure is there for the cerebral circulation. So each organ has got a particular cerebral perfusion or organ perfusion pressure. That is dependent on two factors. One is the mean arterial pressure, which is the main perfusion pressure for all the organs, okay, minus the resistance offered by that particular organ. Okay. So that also has to be included. The importance of rate is very, very important. Okay. So the rate induced ischemia is one condition where, because of, as you said, the diastolic time is very much reduced. So the perfusion of the left ventricle mainly occurs during diastole. You said right ventricle gets perfused both during diastole and systole. How is it possible?
In systole only it receives little high blood supply, sir. Because of the
Okay,
pressure gradient.
what is the reason?
Because of the pressure gradient.
Is it because of the pressure gradient or is it because of the muscle mass?
Okay,
Which
sir.
is much thicker, left ventricle or right ventricle?
Left ventricle.
Left ventricle has got more muscle mass. Okay, so the vessels get compressed during systole in left ventricle. Because of the less muscle mass, the vessels don't get that much compressed in right ventricular systole. Okay, so that is the time when more perfusion occurs. So the main difference between these two is because of the muscle mass thickness, and the caliber of the vessel is very important. Have you heard of a term called endocardial viability ratio?
Yes, sir.
What is that? Why endocardium? How does it get perfused? You said the three layers: epicardium, myocardium, and endocardium. There are three layers. No, what is the blood supply to the endocardium? Is there a direct blood vessel supply to the endocardium? You said the end arteries are finishing in the
In the
subendocardial tissue,
yes, sir.
isn't it?
Yes.
So how does the endocardium get its blood supply, which is the main lining layer filled with the cells? If the blood vessels are finishing as end arteries at the subendocardial level after crossing the myocardial muscle mass, how does the endocardium get its blood supply? It gets the blood supply directly from the blood bathing them inside the cavity. Okay,
Okay.
so
Okay.
that is the main supply to the endocardium is from the blood which is bathing or which is occupying the cavities of the right ventricle, left ventricle, right atrium, left atrium. So there is no direct blood supply. And once the occlusion occurs at the higher level in the muscular branches, then endocardium will suffer more. That is why it's called not endocardial ischemia, but it is called subendocardial ischemia. Okay? And that is the earliest thing to happen before a major myocyte ischemia occurs. And that is what you have to identify during intraoperative phase. Subendocardial ischemia is the earliest sign of a major ischemic attack happening. And which particular ECG lead will tell you that there is a subendocardial ischemia occurring? Your standard L2 lead, will it tell you about this? Or do you have to place the leads in such a way you have to call a different type of lead presentation? Have you heard of CM5 configuration of lead placement?
No, sir.
No. Okay. So there is a configuration called CM5 and the central manubrium 5 position. That is where what you have to do is take the right arm lead, which you place usually on the right shoulder or the right side on the manubrium sterni. Okay, and put the left arm lead on the apical place where the apex beat is there, and the left leg lead will be on the left side. So if this placement is done, this is called the CM5 configuration. That is in the V5 position, we are putting the left arm lead. And this is the most sensitive configuration for identifying subendocardial ischemia, where ST segment depression will happen at the earliest. Okay? So that is how we have to. So if a known coronary artery patient comes for any major surgery, it is better to have the CM5 configuration so that you can pick up the ST segment changes at the earliest before it goes into a full-blown myocardial muscle damage with ischemia or infarction. Okay? And the location of the ischemia or occlusion, that is also very important. Only if you know the anatomy, you can find out from the ECG whether it is an occlusion in the left anterior descending or left circumflex or right coronary. So which are all the leads which will tell you that there is a problem with the right coronary vessel? Which ECG leads you have to look for to see whether there is an occlusion in the right coronary? You have to look at the lead 2, lead 3, and AVF. Okay, these are the three leads where an ST segment depression or elevation or T-wave inversion, if they happen, it is called inferior wall infarction or ischemia. That you have to identify from lead 2, lead 3, and AVF. Whereas the anterior wall ischemia, which is mainly because of the left anterior descending artery, which is supplying a major portion of the left ventricle, you will have to see it in V3 and V4. And lateral, it would be V1, V5, V6. Okay? So the more as you place the ECG leads more and more lateral, it is called lateral and anterolateral ischemia will have to be identified. So three locations mainly: right coronary occlusion called inferior, left anterior descending called anterior, and spread over to the circumflex and lateral aspect of the heart is called anterolateral ischemia or infarction. Okay, so this also can be identified only if you have the correct knowledge about the anatomy of the coronary vessels. Okay, so these are all the points that you have to keep in mind. So I'll just go to show the presentation on that to make you understand these points more clearly.